Good morning. Good morning. It's my pleasure to introduce our speaker today. It's, as many of you know, Dr. Don Jenkins. I've known Dr. Jenkins for a very, very long time. I had the pleasure and privilege of working with him. Don, originally from Pennsylvania, went to undergraduate at Scranton, went to medical school at the Uniformed Services University for Health Sciences, where he was an honors graduate. From there, ultimately did his surgical residency at Wilford Hall. And following Wilford Hall, had a very distinguished career in the Air Force. I believe Don has received almost every award a physician can receive from the U.S. Air Force. And I think he has. And it's good when you have people helping you with the intro. Following, Don was, there's a few people in the room who were involved in this too, but Don was one of the key architects of the joint trauma theater system in Iraq and Afghanistan that I think really made a difference in survival and outcomes in our long conflict. Following separation from the Air Force, he went to the Mayo Clinic where he was the division chief of trauma, where he excelled in every facet. In 2014, Don received the American Legion's highest award it can give, the Distinguished Service Medal. Previous recipients include Henry Kissinger, President Bush. I could keep going, but Don has been on the faculty here for the past, it's hard to believe, but about a year and a half now, and has been our American College of Surgeons NSQIP surgical champion, and has done and doing a great job. It's my pleasure to introduce Dr. Jenkins.
Well, good morning. Thank you for that very generous introduction, Dr. Stewart. Thanks for everyone being here this morning. Make sure that if you're on the faculty, you want to CME credit, there are some questions over there for you to fill in. So we're going to talk about this American College of Surgeons and the Surgical Infection Society update. This was compiled in 2016, published in January of this year per this citation. I'd like to thank Dr. Stewart and especially Christy and her group for helping us try to make things better here in terms of patient outcomes. It becomes increasingly important as we look at surgeon-specific registries and our outcomes. Unfortunately, a lot of these recommendations don't have weighted strength to them. They are the recommendations from the American College of Surgeons, and we felt that it was important to provide you with this update and this information. So we'll just get right into it. So there are intrinsic surgical site infection non-modifiable risk factors. So you can't make your patient younger. As much as we would like to be able to change our own age, perhaps, and you can't change the fact that they've had a history of infection or that they've recently received radiation. So these are things you just have to take into account as you discuss with the patient their risks and as you approach the procedure you're going to perform. These are potentially modifiable risk factors: diabetes, obesity, alcoholism, patient being a current smoker, low albumin, high bilirubin, or them being immunosuppressed. Again, potentially modifiable. Not all of these are completely modifiable in our patient population, just to be taken into account as we discuss with our patients about their risk of infection. Procedure-related factors that go into surgical site infection include: is this an emergency procedure? How complex is this operation? And those with more contaminated wounds. I would implore all of the residents and the faculty, if you're operating here, there are laminated sheets on the wall in each of the operating rooms that identify the wound classification. And I can tell you that in my personal practice, at every operation, I quiz the residents and the nursing staff as to what the wound classification is. And I would say that less than 50% of the time do we get that right on the first go. This is not guesswork. You go to the laminated sheet, read what it says, and put down the proper wound classification. The risk to you is underclassifying a wound that results in a wound infection can raise your infection rates for surgical site infections for wounds type 1 and 2. And those are things that are reportable and can be held against you. So if you get a wound infection and you listed it as a type 2 wound instead of a type 3 or even type 4, which is oftentimes the case, then you're putting yourself at undue scrutiny, if you will. I don't think we have any facility issues here, but these are things that we have to take into account as we think about where we operate on our patients. So other factors that come into play is, does the patient already have an infection? Did we properly prepare the operative site? And did we get the timing, dose, and type of antibiotic right in order to help prevent infection for us? And then the hair removal method. What would you think is the best way of removing the hair? Shave the day before? So if you don't have to remove any hair, don't remove any hair. But if you have to clip, you should clip. And that should be done in the immediate preoperative period. Some people will do that outside of the operating room. Some will do it in. There's some evidence to support that doing it just before going to the operating room may be better. And then keeping the blood sugar under control during that procedure. During the operation, the longer the procedure, the more likely that there is infection. If the patient needs transfusion, or if you break aseptic technique, which you have to watch very carefully in the operating rooms at University Hospital. They set up that little bin in the back with the warmer for the fluid, and it's got a little plastic bag, and it always seems to be right in the path of traffic. That's supposed to be sterile, so you got to keep an eye on those things. Redosing that antibiotic as appropriate if there's significant blood loss or prolonged duration of the operation. I personally double glove all the time. Don't know what everyone else's practice is, but making sure that you do that in a proper fashion. Using the proper surgical scrub is also important. So these preoperative bathing, routine preoperative bathing with chlorhexidine decreases skin surface pathogen concentrations, but has not been shown to reduce surgical site infection. This is a bit controversial in terms of what should we do. Christy, you've helped us put in place a protocol where the patients get a little bottle of wash, is that correct? That they can wash ahead of time. Important to get those to our patients in the pre-op clinic area. There are plenty of patients we operate on that are already in the hospital. They should be getting chlorhexidine baths on arrival and at least on a daily basis to help prevent that from happening. One little side tip, it is not in these protocols, but many of our patients receive chemoprophylaxis for venous thromboembolism disease, and so they put those sub-Q heparin shots. And where do the nurses typically put those? On the abdominal wall, right where you end up bringing up an ostomy where there's now a big hematoma in the sub-Q tissues. So to the surgical residents, please make sure that the nursing team, if there's a patient at risk of having an abdominal operation, that they're putting those heparin shots somewhere other than the abdominal wall. Getting the patient to quit smoking 4 to 6 weeks before surgery is another important factor. If the patient quits smoking inside of that time frame, it actually increases their risk of pneumonia. There are plenty of ways of helping a patient get off of cigarettes and stop smoking. And if you need help with that, there are folks in our clinics that can help us to do that. It is interesting to me that glucose control is a big thing that we want to keep in mind as we deal with our patients, but that the hemoglobin A1C doesn't seem to correlate to infection risk. I don't know why that is. I don't know if we don't have enough evidence yet, or it's not a good measure of diabetes control in the short term. Whether or not we screen our patients for MRSA, I think, is an individual clinical decision, and that should be based upon the factors in your hospital as to what the prevalence of MRSA is in your facility. If you do MRSA screening and decolonization, it does seem to benefit the patients, but it has to be adhered to on a strict protocol. Otherwise, you won't see the benefit you're looking for. So there is no standard out there for decolonization that's supported by the literature, but they should be completed as close to the time of surgery as possible if you want them to be most fully effective. And there's no reason to use vancomycin in MRSA negative patients unless there are allergies that get in the way of using other antibiotics. Combination of mechanical and oral antibiotic regimen is recommended for all elective colectomies. Dr. Perry, is that in your practice?
That is correct.
Are there times that we don't give oral antibiotics?
Not in mine.
Thank you. Glucose control, trying to keep that glucose not too high, not too low in the perioperative, intraoperative, postoperative period is a strong recommendation. And getting the blood glucose too low has actually been shown to demonstrate some adverse outcomes. So having that glucose control is important during the conduct of an operation. As Armand said, hair removal should be avoided. Mohammed, I'm sorry, you said that. Yeah. You just, sit. Oh, boy. So alcohol-containing preparations should be used unless a contraindication exists that would include the fire hazard to the patient. I find it interesting that there is no discussion here that I know of that takes place in that preoperative briefing about the fire hazard for our patients. There are scoring systems for this. I think it is something that we should adopt. Perhaps we haven't had a fire in some time, and this just hasn't really come up here at University Hospital, but I think we should probably take that into account. While there is no superior agent when it is combined with alcohol, if you don't use an alcohol-containing preparation, then chlorhexidine is recommended for that skin preparation. The waterless chlorhexidine scrub is as effective as traditional water scrub. It requires less time, and there really isn't any superior way of washing your hands or prepping your hands if you do what the manufacturer instructs you to do. There is little to no evidence to suggest that the AORN and the Joint Commission ban on skull caps is effective in any way, shape, or form. I love this. I personally wear a skull cap, and I just wear it like at home if I can, just because sticking it to the man.
You are the man.
So you gotta have that thing clean, and that helps. I've never understood when a surgeon is entirely bald what good any hat does, but that's not for me to say. You still got to wear the hat, just skin cells, because they're not on your arms or your face or anywhere else. Yeah. Prophylactic antibiotics only when indicated, and it should be chosen by what type of a procedure it is and the pathogens most likely to cause a surgical site infection. They should be administered within 1 hour. And I think that you know, the key here is that it doesn't go into this level of detail in the recommendations, but there should be a, you know, the highest concentration tissue level antibiotic at the time of the incision. So this notion that we're going to use vancomycin and we get 3 drips in to that infusion in the operating room and then cut skin, or the fact we push some Ansef 30 seconds before we make our incision, we're probably kidding ourselves in terms of having adequate tissue levels of antibiotics. So making sure that those antibiotics are administered in a timely fashion is quite important. Redosing after a single half-life or more than 1,500 cc's of blood loss. And there's your, you know, notion that if you administer it after the incision is made, that it can have any effect whatsoever. Maintaining the patient's body temperature in normothermia is important as well. And it is recommended that patients get preoperative and intraoperative warming as need be. That's one of those things that the temperature is often difficult to see on the monitor that anesthesia has. I can't tell you how many times I'm surprised when I say, "What's the patient's temperature?" Oh, let me put the temp probe in. We've been operating for an hour and we don't have a temp. Okay, let's monitor the patient's temperature, please, and get them normalized. Now, I think that the OR teams, the anesthesia teams, are very good about putting on forced warmed air, bear hugger type devices on our patients, but you know, maintaining that body temperature in balance with your comfort, right? Because there's something about sweating into the wound. I don't know, Brian. I think that every patient I operated on in Iraq got some of my personal sweat in their wound. There's only so much you can do under adverse circumstances. Use an impervious plastic wound protector can prevent surgical site infections. Here at the University Hospital, for quite a while, they had only one size, and one size does not fit all when it comes to wound protectors. And so they've changed the inventory a bit for us now. They come in a variety of sizes, and we recommend that they be used especially in colorectal and biliary procedures. Interesting, I've not used an antibiotic impregnated suture before, but it is a recommendation from the American. Rich, do you do that? Anybody? Anybody do that? I have no idea. Sorry? I said that exists. Well, apparently, so I thought it was the naive one. So maybe I'll look into that and send the faculty a note when. Christy, you're taking a note? Thank you. I won't remember. Oh, double gloves is recommended. Just saying.
That's for you and the patient.
Yes, everyone. And I can tell you, having operated on a patient with the highest hepatitis C titers that our infectious disease department had ever seen up in Rochester, who had swallowed a bunch of push pins in a suicide attempt. I didn't let the resident touch the bowel. The very last push pin went into my thumb. And I turned hepatitis C positive, and then about 6 months later, negative. No antibody, no RNA, or anything. But that even with double gloves, you can't be careful enough in that setting. So changing gowns, gloves, and instruments before closing in a colorectal case is recommended. Christy, do we have a pathway for that? Is there a protocol for that at the University Hospital? Yes, the colon bundle.
It's very easy for them It's just one of those small trays, as small as like the tray trays. And then they do that at Westover. Pretty easy for the techs to set that up.
Yes. And our patients are increasingly intelligent when it comes to getting their health care, and they understand these things. It's easy enough to look up on the internet, and following the protocol is, if you don't follow the protocol, it should be because there is a really good reason. There is some very strong exception that's going to change things for you. Otherwise, you should follow the protocol. Again, strong evidence from the American College of Surgeons that when following the colon bundle, the more compliant you are with more steps, the lower your risk of infection. I won't steal her thunder, but Christy in the next month is going to show you what has been happening here in the past year and a half with our colon-related surgical site infections, and it's a good news story. There is really no high-quality evidence about wound closure in these cases. I think that the use of an incisional vacuum device is not a part of the recommendations here, but it probably will be in the not-too-distant future because it does seem to pull off some of the wound effluent and perhaps will help us decrease our infection rate further. Topical antibiotics do have a role in some operations, probably not in the majority of the operations that we perform. So there's really no good evidence to support that in our hands. Supplemental oxygen for our patients is important as well to help us fight surgical site infections. And the problem that we run into most frequently not adhering to this for the 2 hours post-operatively is actually in our intensive care unit. Because when the patient arrives, the first thing that respiratory therapy and the nurses do is turn down the FiO2. It's a part of the weaning and extubation process, and we don't take that into account. So you surgical residents and faculty who are admitting your patients to the intensive care unit, you have to pay attention to this one detail. Because it is not a standard thing for our teams to consider in the intensive care unit. As we do this more and more, and it becomes more commonplace, and it will become a rote thing that we do. But please pay attention to those details in that surgical intensive care unit setting. When I was a resident, if you touched that surgical dressing, before the chief resident or the faculty came by to check that wound, you ran the risk of losing a finger. But there's thankfully no evidence to support that you should lose a finger over taking that dressing down. And that early showering doesn't change the risk of infection. And in colorectal cases and vascular groin cases, it does seem that there is a decrease in surgical site infections using that negative pressure wound therapy over the incision. And that in contaminated wounds, checking that wound on a regular basis can help decrease surgical site infections. There's no formal wound care protocol described for the post-discharge setting for patients. That would be called the art of medicine or the art of surgery, as it may be, and we'll leave that up to the individual surgeons. We also have some difficulty identifying infections in that setting for our patients. The dull rubor that comes with a wound hematoma, often confused with a surgical site infection. Not uncommon for a patient to be seen in the outpatient setting by someone who is not their surgeon to be placed on antibiotics. The second you get put on antibiotics, it becomes a wound infection for all intents and purposes. That's why you have to very carefully examine those wounds, and you should work with all of the members of your team to try to get that right. If there's an infection, there's an infection, but if there's not, we shouldn't be calling it an infection or treating it as an infection. Separate publication in that same issue of the Journal of the American College of Surgeons on Class 1 wounds. Another publication here from the Mayo Clinic about intraoperative hypothermia in our patient population presents us that, a bit of a dilemma. When we're talking about type 1 wounds, hypothermia is recommended by the American College of Surgeons to be avoided at all costs. However, in this study, they looked at nearly 10 years worth of patients, and they found that when they studied the Surgical Care Improvement Project performance measures in this patient population and followed them for surgical site infection, that compliance with the measures in type 1 wounds, to include temperature control, did not change the surgical site infection rate. In fact, the higher the nadir temperature was associated, and the cumulative hypothermia over the course of that operation was not associated with surgical site infection. So just some of the evidence we have to reconcile for ourselves, but this is again dealing with type 1 wounds only, not anything else. And so I still believe that while this evidence can support not monitoring temperature in these patients, that as a surgical practice, this is where if we fall away from a standard, that it's easier to fall away from the standard in the next case. Is it plausible that a type 1 wound could become a type 2 wound during the conduct of an operation? Yeah, certainly. And so that's not taken into account, and they don't talk about that in this publication. So even though it was not associated with surgical site infection, probably still is a very good practice for us overall. So with that, I would like to say thank you very much for your time and attention here today. If you need those references, I think that Sylvia is going to make sure that this lecture is put up on the website for the department, and I'd be happy to try to answer any of your questions, but Christy's really the expert, so we can let her answer them too.
Questions for Dr. Jenkins?
Dr. Srinick.
Don, your point about double gloving is really hits the mark. One of our anesthesiologists did a study here showing that there was a hole in the glove within 30 to 45 minutes, looking at electrical gradients.
Yeah, I also use a indicator glove, right? So a darker colored glove with a lighter colored glove over the top so that you can see if any moisture is entered in between the two layers.
Most of us started double gloving before knowing about Hep C or AIDS, so we didn't get injured with the fire stick ourselves.
Yeah, good point. Yes?
I'm very interested in this idea of using a wound vac to decrease surgical site infection. So how long do you use it? I mean, how long do you put it on, and what's kind of the cost-benefit ratio? I mean, wound vacs aren't free, and so what percent do you think we might decrease surgical site infection?
Yeah, so typically the surgeon will leave that dressing on 3 to 5 days, depending upon their preference for a dressing and that art of surgery, if you will. Some of those devices are, they're mechanical and you got to plug it in, et cetera, et cetera. But they also make a type that you can put on the patient and they can remove the dressing themselves at home and just use a small suction. So the small wound that a patient has can be treated that way, which is far less expensive. As a part, I don't know the cost-benefit ratio. I don't think that has that there. I don't think there's a sufficient amount of data yet. As you see, as part of the recommendations, it's recommended in 2 specific settings: one for the groin for vascular, and one for the abdominal wound for colorectal surgical cases. I have a tendency to use it more frequently myself. Having, we went from having no use of a wound vac, right? Everything is wet to dry, dressing changes on a regular recurring basis, And in my personal practice, we became quite familiar with this in the 2004-2005 timeframe in Iraq. And we use those wound vacs to primarily close, secondarily close, I'm sorry, in a delayed closure fashion, combat injury wounds. Which is, you know, the dogma has been you never close those wounds. And we went from 28-day hospital stay to 7-day hospital stay for local national patients, all with open wounds and getting skin grafts, to closed wounds. And we published case series 75, 80 patients, not a single wound infection in these combat-related wounds. Now, that was not the surface incisional vacuum device. But if you look at the infection-related literature and what wound vacuum devices do in terms of reducing the bioburden and some of the inflammatory markers that are in wound effluent. We had a nice presentation by somebody from the ISR here recently looking at burn wounds, where they put the devices on, saw more rapid healing. The thing they didn't do, and I took them to task over, was why did you not measure what was in the effluent in terms of all the interleukins and other chemotaxins and things that are in there. So.
Kind of along that same line, a very common question that we get from patients is, when can I shower? When can I take? I've always been taught that a surgical wound is sealed in 12 hours. Do you have any comment on that?
That's what one of the recommendations was, Boyd, was that it's okay. There is no increased risk of infection showering at the 12-hour point. Sir?
There is a problem with oral antibiotics. For the last 45 years, we have seen the Nichols.
Condon, yep.
And number one, on the recent studies that shows great benefit, we don't see the side effects. We don't see the compliance of the patients to take these, have they finished all the dosage? Because the usual thing is that the patient comes. Very common, very, very common. So we don't see that in the big studies that we are showing. And number two is the discrepancy across the ocean. The Europeans don't use oral antibiotics. The Americans use oral antibiotics. If pharmaceutical companies play a role in this?
I don't think so. I don't think the pharmaceutical companies. Yeah, generic, and it's
Nobody's making a profit on it.
25 cents a piece. So yeah, I don't.
But I haven't seen that compliance and that side effect.
Yep. So between the potential for vomiting and or because they're taking an oral preparation as well, there are people that have told me that they saw the entire pill can just come out as well. So I think the timing of those antibiotics in conjunction with the oral prep needs to be taken into consideration. I was going to ask Dr. Cigarro, I don't know if there are any specific, because this article did not go into it, in the transplant community, any specific surgical site infection precautions we didn't cover here that would apply in the transplant community.
I think you covered that really well.
Okay.
Question on the preoperative dose of antibiotics. If someone's on scheduled antibiotics, let's say they have diverticulitis, you've got them on 3 times a day dosing, they need an operation, what's your recommended treatment plan for preoperative antibiotics? Do they need something extra in addition to scheduled dosing, or do they need nothing at all?
So although the article does not specifically address that, it's about the tissue levels, right? And so if the patient has appropriate tissue levels of antibiotic because they're on a regular regimen, just so long as you maintain that regimen during the conduct of that operation, give them the antibiotic at the right time, I think that's most appropriate. I don't know if anybody else has a different or better answer than that, but that has been our practice.
Thank you for your talk. I have a question about smoking. I know you mentioned about the 4 to 6 weeks, but most of the patients that I treat have cancer, and I try to get them into surgery within a month. And I, as a physician, I can't tell them to keep from smoking. I tell them at least cut back. Is there any data on any increased infection with cutting back, or
Yeah, I am not aware of any evidence to support decreased perioperative infection rate by cutting back on cigarette use. It is interesting to me that they don't really make any recommendations about oral use of not inhaled use. And there's really nothing out there about e-cigarettes as well either that has very strong evidence to it. Again, in the infection control literature, if you look at that, it all has to do with local tissue hypoxia. And in our patients, then the carbon monoxide load on those red cells instead of oxygen being on those red cells. And then the mucociliary system within the upper airways, right? So those cilia die off, and it takes about 9 days for them to regenerate. It's why most patients, when they quit smoking, about 7 days later, they get this vicious cough, and they're coughing up all kinds of sputum, and it gives them an excuse to get back on cigarettes. See, because you made me sick, doctor. Thank you very much for telling me to quit smoking, not realizing that their system is doing what it should have been doing all along. And it has something to do with that increased production of sputum over that time frame that has something to do with the respiratory risk of infection. I agree with you that there are just some patients, and I ask them quite honestly, is there any chance you're going to be able to quit smoking? Because if you can, then we want you to quit smoking, but I'm not going to withhold an operation. You're just going to know that if you get an infection or some untoward complication, you brought this on you. Don't talk to me about it. You're just taking an extra risk on yourself. So you may as well not buckle up when you drive home today. I tell them that. I do.
So what are your thoughts about potentially including a probiotic? Because when you there's some evidence to support that giving bowel preps affects your microbiome, which also in turn actually can potentially contribute to other complications, so maybe not a surgical site infection, but other complications in the hospital. So what are your thoughts about that?
Well, it's quite interesting, and I think that the jury is out on that. There are some proponents of probiotics. There was a big push when C. diff was really so prevalent over the previous maybe 8 or 10 years to push that. Haven't seen a change in that. It really comes down to hand hygiene in the hospital setting that seems to make all the difference for those patients. Personally, I don't have. Would you just give them yogurt, or are you going to give them a pill, or what are you going to?
So there's some probiotics out there that are used in rheumatoid bowel disease, where if you have a certain count in the probiotic itself, that it has a effect.
Yeah, I don't think anybody knows that. Rich?
Real quick question. So, Don, great talk. I think a little follow-up to Patrick's question, because we're actually being pushed a little bit at Westover when the patient's been on this regimen of antibiotics, diverticulitis, for example, or whatnot, or even gallbladder, that they want us to give a preoperative dose of AMSF before we cut skin, even though they've been on an appropriate antibiotic that would cover that same, So now I'm giving them an extra antibiotic on top of one that they've already been given, just because they don't want to get dinged, and that's kind of been their new protocol switch. So I'm just curious.
Yeah, there really is no evidence to support that. And I personally don't condone that myself.
I think, don't you think that's that depending on when the last dose was received, you could redose the same antibiotic? I think that's
Yes, you could.
Words, if it's been 4 hours, maybe you redose immediately prior to surgery.
You could, absolutely.
What's interesting about all this is there's only certain cases where this kind of matters, even though infection matters in all patients. But the only cases that these are reportable in are the hips, heart, hysterectomies, and colorectal. So
Today,
correct. So it's kind of funny that the hospital and
but they will look at SSI type 1 and type 2 wound infections, and there's a rate for that. And if you're above that 1.5% or 2.5%, depending on their class 1 or class 2 wounds, that is reportable for any of those cases. So, well, very good. I think it's time for M&M. Thank you, sir.